We've a great event here today. It's the first event in UL's Research Week for 2022, and it's one that's very close to the focus of the Health Research Institute at UL, because we really span health sciences both here at the university, and we link very closely to the hospital and to the HSE. And the COVID pandemic has kind of raised the need for investment in public health and to have active researchers who are geared up and ready to deal with these types of challenges. I think it's really exciting. We have a fantastic panel here today, and I'm very much looking forward to the discussion. So what's going to happen is that Professor Philip Nolan is going to do a talk, and then we're going to hear 5 minutes from each of the panelists, and then we'll have questions from the audience. So if you do have a burning question, please save it to the end, when we will have questions from both the live audience and the online audience. So thanks so much for being here today. I think we're going to have a great discussion, and I'm now going to hand over to Professor Kirsten May, President of the University of Limerick, who's going to introduce the panelists. Thank you.
Thank you very much, Alan, for the introduction, and welcome everyone to the panel Learning from the Pandemic, the Power of Data in Public Health. And it gives me enormous pleasure to very warmly welcome Professor Philip Nolan, Director General of the Science Foundation of Ireland. Until last year, Philip headed up Maynooth University as president, but also you will be very much aware of his work as the chair of NEFIT's Irish Epistemological Modeling Advisory Group. And I have to say, in my role as interim president at the time of the pandemic, I really appreciated Philip's very calm and very well-founded advice given to us at the coal phase of developing models of circulating students and staff across the campus. So I just wanted to say how much I appreciated that work of NEFIT and of NEFIT's advisory group. And obviously, data played a crucial part in the modeling advice. In that very eminent panel, we have furthermore Dr. Catherine Motherway, intensive care consultant at the University of Limerick Hospital, but also Limerick Person of the Year 2021, in recognition of all the work that was done, to manage the COVID pandemic. We have a Professor Carl Walsh, Professor of Statistics at the Departments of Mathematics and Statistics, who was also a member of the Irish Epistemological Modeling Advisory Group and contributed significantly to provide the right approach to manage people in workplaces and beyond. We have also on the panel Dr. May Mannix, Director of Public Health Midwest in the Health Service Executive. And Dr. Mannix was recently promoted to consultant in public health medicine after a long fight by the Public Health Director Committee. We are delighted to congratulate Dr. May Mannix and 5 other consultants in public health medicine as they begin their new post. It's a landmark moment for this speciality and the development of public health medicine in Ireland. And last but not least, Professor Aidan Culhane, Professor of Cancer Genomics at the Limerick Digital Cancer Research Center in the School of Medicine. And Aidan joined us recently from Harvard and plays a key part in bringing data and health together in the fight against cancer. So without further ado, I would like to hand over to Professor Philip Nolan for the address.
Thank you very much, Kirsten, for that very kind introduction. And I hope I've offered you additional reassurance by proving to you that there is life after university presidency, and it's very stimulating and enjoyable. It's great to actually simply be here, first of all. Like in an existential sense, we've been through a huge crisis, and then that we are now at the point where we can come together in this setting. I'm really pleased to have received the invitation from the University of Limerick, and I received it just before I started as Director General of SFI, and I accepted it immediately, and I'll explain why in a minute. What I'd like to focus on and I'll do my very best to stick to 20 minutes, somebody please start waving at me after 18 or 19 to stop, is to focus on lessons learned in terms of how we should fund research for optimal societal benefit, using the pandemic as a lesson. So I'm going to focus on not so much the process that we went through, Cathal might want to talk a little bit about that, but what I learned during that process about how we should fund research. And even in thinking about the word societal benefit, perhaps we should be thinking about ecological benefit. This pandemic was an ecosystem crisis. It emerged out of ecological disturbance, and it required a massive human behavioral and scientific response to respond to it. So I'm thinking about how do we fund research that cares for the ecosystem is perhaps a useful way to think about it. A lot derives from the experience with working with colleagues in IMAG and NEFIT. And the reason that I accepted the invitation was it gives me an opportunity to say thank you to this institution. And in particular to say thank you to somebody who's not here, Professor James Gleeson, who was very much, and no offence, Cathal, my right-hand person during this. Many of the models that you saw were built by James. He's such a modest person. He would rather I didn't even mention him, but I have to, because it was an incredibly tough couple of years. And I relied on him and I relied on Cathal, who were absolute pillars of IMAG. And a lot of the things that you might have heard me calmly and confidently explaining to the public was after a long tutorial from the other, including the immortal line from James Gleeson in the middle of one Zoom meeting, well, Philip, you're right, but for the wrong reasons. I think you remember that line, Cathal, actually. So I do have to say that we mobilised extraordinary expertise from this institution. It's also a privilege to be on the same panel as Catherine Motherway. I've met the Donegal Person of the Year and the Limerick Person of the Year in the last fortnight. Catherine, as you know, not only in her clinical leadership, but in her public leadership and her clarity of communication, made a huge personal contribution to the management of the pandemic. And then finally, May Mannix. The interesting thing about this is like Cathal and James and I have met n equal to 0 times physically in the course of the pandemic. We did it all remotely. I met Catherine once, I met May twice. Again, it's a testament to the professionalism of those people that we managed to do all this remotely, because they are so good. You could establish a professional and technical relationship remotely. And of course, May's, and I do extend my congratulations also to that long-delayed acknowledgement of her status as a consultant. And May's colleague in Public Health West, Breda Smith, was a member of IMAG. And again, one of the things that I do want to emphasise in this talk, it only worked because it was a transdisciplinary and engaged effort. It only worked because Breda and Pat Wall and others were there who could say, well, that's all very fine, but when we're in the practice and profession of public health, we need this, and it's not quite what you might think, and we work together in that vein. So, what do I think we learned from the pandemic? I mean, first of all, we have to acknowledge that science, simpliciter, the kind of science that we'd be familiar with in the terms of laboratory science, did provide really important tools to mitigate the impact of the pandemic. However, the profession and practice of public health was what provided the pivotal expertise to take that science and, in this specific instance, control the harms of the pandemic. First, control the infection, because that was the only tool we had, and then with vaccination, control the harms. And we even had a challenge, I think, weaning ourselves off the fact that, you know, we could perhaps move on from controlling infection because we now had other tools to control harm. The one fundamental, I think, I want to emphasize from the perspective of a research funder is that the prior investment over the last 2 decades in particular in scientific engineering and health research is what provided us with the talent. It's what provided us with the Cahals and the James and the Mays, appropriately trained and here because it was possible to conduct their research in professional lives. It provided that base of talent and intellectual capacity, and that was the important thing. Not specifically actually what they've been funded to work on, because most of these people were funded to work on other things. And some of the people that worked with us and were central to the effort weren't funded because it wasn't a national priority at the time. We have to reflect on that, and we have to reflect on it honestly. IMAG, I think, was a really good example of engaged, collaborative and transdisciplinary research, and I think we can learn important lessons from those experiences. Let's just reflect for 1 minute on just how miraculous, when we say science worked and helped us conquer this pandemic. I can trace, I think the first clinical presentation was around the 17th of December 2019 when people began to turn up with this very severe pneumonitis in Wuhan. The genome of that virus was sequenced 25 days later, the sequence published on the 11th of January 2020, and 370 days from the first clinical presentation, there was a highly effective vaccine through clinical trials. If you ever see these slides later, yeah, the clinical trial was 40,000 people, but there were only about 300 infections in the clinical trials. So vaccine trials are complicated. And when we were running around, there were 9 infections in the vaccinated arm and 0 hospitalizations. That doesn't give you a vaccine effectiveness of 100%. It just means you failed to detect any severe disease in the trial. Anyway, science worked. Science is difficult to interpret. Science worked at an extraordinary pace, but only because all of these technologies were available to us. We had, SFI and our colleague agencies had a rapid response call, which was exceptionally effective. I've just listed the projects that went through UL here, from novel inhalable formulations right out to smart manufacturing to overcome supply chain disruption. It wasn't possible at that time to know what we needed. So we did fund a broad base of projects. Many of them were useful at the time. More of them are going to be useful into the future. And we have to think about what we mean by rapid response and when the rapid response research is going to be useful. It was 83 projects. It stretched from intracellular second messaging work right out to socio-behavioral impact. It stretched across the spectrum from fundamental research to very applied, task-oriented research. But I would have to ask a question about it. Was it sufficiently transdisciplinary? How many truly transdisciplinary projects there were there? For instance, where we might have been modeling societal behaviors alongside infection. And how engaged were those research projects? How many of them really got stuck in with public health professionals or manufacturing companies and said, look, we are here to help. How can we help? And the one thing that I think we found missing through all of this was that though we had many effective prior investments, we hadn't invested in the infrastructure for clinical and public health trials. So for instance, we could have, around the debate about HEPA filters in schools, so let's run a trial and see if they work. We know they work in terms of cleaning the air, but do they work in terms of reducing infections? We don't have a lot of infrastructure for that, and we particularly don't have a lot of infrastructure for it when it comes to a population level intervention and whether it's effective. So let me tell you a little bit just about IMAG. I got a phone call at 8 o'clock on a Sunday morning from somebody I hadn't talked to in about 10 years, the Chief Medical Officer, Tony Hill, and he said, is there anybody who does mathematical modelling of infectious disease? And I kind of went, well, I don't know. Within a week, we had pulled together a group of applied mathematicians, biostatisticians, computer scientists, epidemiologists, and I'll come to them in a minute, and public health professionals. It expanded to be about 40 or 50 people. We were meeting weekly or twice weekly, and with a huge amount of effort. The first thing we could do, because we had no idea really about the dynamics of the transmission of this virus, the first thing we could do was say, well, what might happen? And this is a slide from a very early press conference. It was done by Brendan Murphy in UCD and Chris Brunson in Maynooth. We said, okay, the first thing we can do is just simple exponential growth projections. And the black line was the native growth of the virus, 33% growth in infections per day in an unmitigated scenario. And then we looked at simply different growth rates, and the blue dots then are the case numbers, the cumulative case numbers over time. And at least we could see that the measures government had put in place in that time were mitigating. Not enough, it turns out, but they were mitigating the response. The next step was to build what's called an SEIR model, and this is where James Leeson came into his own, and a lot of the biological interpretation was mediated by Cahill, who understood the world of mathematics and the world of biology very well. And that simply divides the population into a starting group who are susceptible. They become exposed to a small number of infected people, that's the I, and that gives you a rate at which susceptible people become exposed. After a latent period, they are then themselves infectious and they start to infect new susceptibles. And when they recover, if you're being nice about it, the R stands for recovered. If you're being brutal about it, the R stands for removed, because you either sadly recover or die. So it's a susceptible, exposed, infectious, infected, and removed model. If you're James Leeson, you can describe that as a set of equations. The problem is, if you look at those, there's a lot of parameters. How many, the famous reproduction number, or the number of susceptibles who become infected over time, is a related parameter called beta. What's the latent period? What's the time between when I'm infected and I start to infect you? We didn't know any of those. Who did we turn to the most? So we could build a model, but you could get anything out of the model depending on what assumptions you put in. So we needed to put in some assumptions. And this is where a very interesting group came into their own. These were a group of veterinary epidemiologists. These are a group of people actually who find it very hard to be funded within our system. Human epidemiologists have moved on. They're much more interested in non-communicable diseases like obesity and cancer. Much of our reservoir in terms of expertise in infectious disease epidemiology is in animal health. And of course, animal health and human health are related. Within 2 weeks, these people have put together pretty good estimates. We could see estimates other countries were using coming out 10 days, 2 weeks later, of all of these important parameters. And that allowed us to build a proper model. And this, again, is one of James's models. This is the one that we used in May 2020 to say to government, if you start opening up now, the thing will just take off again. That's what those red and amber lines are. We convinced them to maintain the public health measures in place in a phased manner through June and into July, through May and June really, and that's the grey line, and then the dots again are the actuals, and they did follow the grey line model with a very low reproduction number. As we got more sophisticated, we encountered a really knotty problem, which I think May would be more than familiar with. We had vast amounts of data, but the data was, so we had PCR tests, we had later then the contact management program, separate from public health departments who were tracking kind of routine cases. We had antigen tests coming later, we had genotypes, we had vaccination, we had the number of people going into hospital. But just as one example, if I tested positive for COVID in Scotland or Denmark today, and I attended an emergency department in Scotland or Denmark in 48 hours' time, because both countries have unique health identifiers, they knew who I was. Here, we didn't know it was the same person. So there was a Philip Nolan tested positive in Blanchardstown on the 2nd of July, and Philip Nolan turns up in the Mater Hospital 4 days later. No connection. And that's the single biggest learning for me, is that we need a massive investment in data for health. And all of the governance and privacy and so on issues need to be resolved. And it's something that we have huge expertise in this country, and a lot of it is funded by the agency that I run. We need to mobilize that expertise. A point I want to make about this is a later model. The first up and down is the March 2020 surge of disease controlled by the public health measures at the time. Then we all relaxed because one has to. And through the summer, you can see the second peak there, we began to see case numbers rising again. It wasn't when the schools opened in September 2020. The seeds of it were laid as soon as we opened up in, if you plot 4% growth from the 22nd of June 2020, you get where we were monotonically. So we had the October lockdown. And this is us, and Carl will remember this slide, this is us going into Cabinet with James's models to say, here's what we think will happen if we open up over Christmas. And we made a couple of mistakes in presenting this slide. We were at 200 cases a day and falling. and we were going in and saying, look, things could go badly wrong here. And we set a threshold in our heads. We said you could be back up through 400 cases a day in January. And that 400 cases a day stuck in the mind of the hearer as a reassuring figure, as opposed to, you're accelerating through 400 massively. You can see the red curve there, which is, basically opening up hospitality and lots of household visits over Christmas, and you'll be absolutely in the wrong place. And in fact, we even said it in the letter. That's a quote from the letter that I helped draft, that went to the minister, that said if R exceeds 1.2, and the significant certainty, cases could exceed 400. And what did that teach us? It taught us that I wasn't communicating the outputs of these models as well as was necessary to properly inform. And there's a whole science around that, actually, that again we need to think about. We need to be better at kind of communicating the range of possibilities and uncertainties and so on. Not only that, as soon as this was over, we were starting to vaccinate people. So we had to put vaccination and prior immunity, and of course what arrived in the middle of this, only alpha. We're sitting there going, the only thing that could make this worse would be a more transmissible variant, and here it comes. So this is the same model. So from 4 months later, and James has adapted it, first of all, to include vaccination, and second of all, to have the model run 100 times with a range of parameter sets, just to illustrate quite clearly. These things are not definite. There's a range of uncertainty around them. And you have to think about your policy formation in terms of, it's not that we don't know anything, we just feel it's more likely to fall in this range than this range, and you need to make your policy decisions on the basis of you're likely to end up here and less likely to end up here. And what those three plots are is what might have happened if we'd opened up on the 5th of April 2021, the 3rd of May 2021, and the 31st of May. And what you can see is in terms of case counts, allowing for the range of uncertainty, a significant attenuation of any wave of disease that might emerge if you just hold off for 8 weeks. And that was an argument, I guess, we'd had the experience of January 2021, which was chastening to say the least. But I think this much clearer presentation where you're communicating uncertainty, but also communicating with confidence, was a much better policy presentation. And then finally, to acknowledge just how sophisticated this became, to acknowledge a colleague in Galway, Jim Duggan, who had been working away a monumental amount of work to take the model, break the population up into different age cohorts, allow for children to be different from adults, and it was that model that kind of got us through the late summer and early. It's hard to emphasize just how tough it is to build something like this. He worked, basically, James figured out how to make it as simple as possible, and then Jim could use that then. And I'm coming very close to a conclusion. This is to illustrate the following concept. For 18 months, colleagues had been working a massive voluntary effort. It wasn't in any way going to advance their academic careers because it wasn't original in that sense. It was engaged research. That said, and James is a very humble individual. He was invited by the Royal Statistical Society to present how did you incorporate vaccination into the models, and he'd done it very cleverly. There was a complicated way to do it, and then he found basically a mathematical simplification of that. That's the simplification. And beside it is the publication of the Philosophical Transactions. So in fact, his colleagues saw this as quite original and significantly original and worthy of publication. So what people did here, because of the base they were building on and their talent, was simply world class, to the point where colleagues internationally said, yeah, we actually want to know how to do that. Well done. So to close out, in terms of learning from the pandemic, the first thing that I learned is when the emergency arrived, and it's kind of illustrative, it's almost like a parable of an emergency. If you think about what we went through and think about the fact that the same thing is happening just more slowly with the climate emergency, we could mobilize people. We could mobilize them because we had them there, and we could mobilize them because we had invested in science across the full range of disciplines. So that's the first thing. We need to continue that. This is an argument for broadening our investment in research right across science and engineering, social sciences and humanities, not an argument for trying to figure out what is it we need, because frequently we don't know until it happens. Secondly, there's such a strong argument for systematic investment in public health through strong regional departments such as the one that May runs, with the national system be there for governance, strategy, policy, providing data and analytics and so on, building strong academic links between that and the university system where we work together, a plea for integrated data infrastructures with the unique health identifier. That's not just going to help us with this, it's going to help us with everything. We need to value biostatistical, epidemiological modelling and trials expertise. They're all actually different disciplines, and we don't value them as much as we value other things. And there's huge value in taking a One Health perspective, particularly to infectious disease, but not just infectious disease, and to begin to think ecologically rather than in a human-centric way. I highlighted the importance of systematic review. There was a lot of people coming out saying, well, I can tell you that the virus does this. And then there were teams of people slaving away through the literature emergent at the time and saying, our best estimate is it looks like this. The Seir program trained a lot of those. And this brings me to my next point. Also the data science program. So those programs that are training doctoral graduates that are able to do these very sophisticated things are vital. And then finally, there's this value when we come to any major challenge to mobilizing a collaborative, engaged, and transdisciplinary effort. And you could summarize it into investment in research challenge, systematic investment in public health. And I think there's a challenge now for us as funders and you as institutions, because when it comes to doing this kind of work, engaged, collaborative, and transdisciplinary research, we haven't fully cracked how do we mobilize people to do it, how do we fund it, how do we recognize it, and how do we reward it? And that's the challenge I leave with you. I think we've learned some lessons and I can say I know what to do about them. But when it comes to that, how do we really get people in behind these challenges and recognize and reward that when they're productive in non-traditional ways is something that I'm not entirely certain. I've learned to live with uncertainty over the last couple of years, but it's the thing I'm least certain about is what we can do as a collective of funding agencies and institutions to reward, engage, collaborative and transdisciplinary research. I hope that was helpful. I'm sure it was too long, but thank you very much indeed.
Very much for your extremely illuminating and very reflective and frank presentation. And I know panel members have prepared a 5-minute response to that. And my suggestion would be that we take perhaps Carol first as from the modeling, then May from the public health, then Catherine from the acute care, and then Aideen perhaps in the wider field of health and data. Carol, can I hand over to you?
Very good. Thanks very much, Kirsten. And thanks very much, Philip. It's great to see you here. And as Philip mentioned, it's the first time that we've sort of met in person throughout this whole pandemic. I suppose I've 3 points, and they echo a lot of what Philip has said already. One was that we were at a population level, we were more fortunate here than some other countries. That Ireland actually did very well throughout this, even though at an individual level, I know it has affected a lot of people. So when we look at the impact in terms of excess mortality, it's less here than the majority of other European countries. And that's in no small part to the work that we've done. Going back to remembering about 2 years ago, and I didn't get a phone call, I got a text message, I think, on the Sunday morning, and I still thought it was a bit later, it was 11 o'clock, I think, on the Sunday morning. So it shows how quick things move when they have to. And it's through the leadership of our public health professionals and through Philip, through your own work, that we were able to build on a network of contacts and bring them together to work on these models at very, very short notice. The group came from all over the country, and it was arranged within days, and certainly within weeks, we had working models. And you've seen some of the outputs of the modelling work there. And in fact, we had 3 different levels of modelling as well going on. So there was the high-level SEI or age cohorted modelling, agent-based simulations as well. So there was a substantial modelling effort behind all of this. The disciplines were distinct disciplines of computer science, of statistics, I say biostatistics separately, data engineering, spatial and temporal modelling from colleagues in Maynooth and UCD as well, and epidemiology. People say epidemiology as if it's one thing, but of course, we often say things like, oh, well, you need a statistical epidemiologist, or you need an infectious disease epidemiologist, and they're all sub-disciplines in their own right. We were quite careful about the parameterization of models, and one of the things that came out of our evidence review was that one of the parameters, something called generation time, our estimate of it, was shorter than the UK working estimate. So we, at an early stage, recognized that the number of cases could double more quickly than they recognized in the UK. We acted quicker here. We acted conservatively, but it turned out that we acted correctly. There was another element to this, and that was the question of herd immunity that was going on in the UK. Because of their flu-specific models, they felt that that was something to use. So ironically, even though the infrastructure was better in England, we did better here in terms of our reaction to it. We didn't get lucky just because we were lucky. As we know, we make our own luck in this world. It just so happened that the European-funded research group, Pandem, on pandemic response and security, was centred here in Ireland, in Galway, and it was being led out of Galway. So, and interestingly, it wasn't funded through health, it was funded through the European programme on security. So security funded our response and funded it through Ireland. Science Foundation Ireland had invested substantially in analytics research through Insight, and UL had just recently joined Insight just the year before, had become a member. MAXI is a centre that people will know, so Maths Applications Consortium for Science and Industry, that was run out of UL, funded through an SFI grant for James Gleeson. And they had worked with industry colleagues on maths modelling, not much on biological systems really, or infectious diseases, but actually the models have a similar shape, so any diffusion process has a similar shape to an infectious transmission process. Sometimes we give out about mathematicians that we're sort of interested in the idea rather than in the practice, but maths modelling for industry is a real hands-on science, if you like, and certainly when it came to modelling of populations, that was useful expertise. The Health Research Board had funded a Research Leader Award for me in the area of infectious disease modelling, as it happened, more to do with reimbursement of products and things like screening and vaccination programs. They also funded Applied Partnership Awards, so we've been working with, and I said it to May, I don't know if May wanted me to say it, but we did have a conference just before the pandemic on social inequalities in health. So we'd already been working quite closely with professionals, health professionals in the area. So we established, because we'd already been working together, we were able to activate those networks quickly. It's fortuitous as well that I'd been working, before I came to UL, I'd worked on vaccinations, but I worked vaccinations of horses with the Equine Centre in Kildare. And in fact, had published with our current Dean of Science and Engineering, but we never met. We did the old-fashioned, we didn't do Zoom calls, we did the old-fashioned way of emails. More or less, have you done that analysis yet? Be replying, not yet. You know, this sort of thing. but we actually were quite productive in a lot of the work we'd done. And so through that context, we'd known of the centre in UCD as well. And it's not just true in Ireland, I think it's true across the world, that agricultural epidemiology and veterinary epidemiology is much more advanced in the area of infectious diseases than a lot of the work with human transmission. Because, you know, animals move in particular ways and it becomes complicated, and perhaps we don't have as much sensing of animals as well. So that was a very useful previous collaboration as well. So it's not just about building specific expertise, but it's building networks of expertise and connections between those networks that I think has been successful and will be successful into the future. We should learn from the past. We should, of course, document our experiences throughout this pandemic. We've had previous pandemics, HIV, TB, poliomyelitis, cholera. In fact, there's an interesting play being shown next week, I think, called Miasma, which reflects on the cholera pandemic. And it echoes some of our challenges that we had here as well. Certainly, better information systems we need. A single health identifier was a frustration that we all recognize as a challenge. An ability to enhance surveillance. These are areas within computer science and computer engineering that colleagues have already, I think, identified, and I think certainly is something that we should change right quickly. Very much so, the CRT that's here in data science, foundations of data science and analytics, will bring the next generation of researchers out. The Sphere program brings the next generation of health researchers out as well, so I certainly echo that. We should also learn how to bring together, because it's not just about infectious diseases. We have climate challenges. We have existing challenges in terms of obesity, those are epidemiological challenges in cancer. And so learning to work together between health professionals, basic scientists, and community is where we need to go with this. The last point that Philip made there about the challenge of connecting and bringing together transdisciplinary research, I think we've already seen some of that in the way that UL in particular has put resources into the Clinical Research Centre. With initiatives like the SALI initiatives, where we've got 2 new professors in data science and in related quantitative disciplines in the area of cancer, who will speak herself later. So they are initiatives where we have had investment. And of course, the Health Research Institute, which brings together people from across the sciences and scientific disciplines. And I think UL is well placed in this area. Thanks.
Thank you very much, Carl, for your response. Can I invite you now for your response?
Thank you, Professor May, and thank you for the invitation here today. I really appreciate it. Thanks to Philip and his team as well. We certainly used your data all through the pandemic. As a practicing public health doctor on the ground, I suppose I'm going to reflect a few learnings which relate to what Philip has been talking about, but they're probably specific to somebody who's been working through the pandemic in public health over the past over 2 years now. And one relates to the whole point about surveillance. So Cathal has also mentioned that. And surveillance is, in simple terms, it's the information we use for action. So in practice, we have a system which nearly everybody knows about now since the pandemic, called a CIDR, where diseases are notified to us, infectious diseases are notified to us. And we also have a system where it's an early warning system, essentially, where if there's an unusual kind of a disease, that comes to our attention also. And surveillance also helps us to monitor the effects of the interventions, obviously. So, for instance, if you introduce a new vaccine, such as MenB, well, thankfully we've seen a dramatic drop in the incidence of those diseases. So, I suppose before the pandemic, it was recognized by the World Bank that there was kind of chronic underinvestment in this area. And I think the pandemic certainly brought that to the fore. We need faster, more real-time data. I think the other thing, though, is that we need to think on a world stage, really, because where we're likely to get the next pandemic is, unfortunately, in a country that has the least surveillance system, the least support to actually report it. So I think we really have to think internationally about this. And certainly, as everybody has said, we need systems that can talk to each other at an international level. And to do that, we'll need to harmonize kind of how our disease categories and also the IT side of it, the technical standards. You know, I suppose one of the reasons people give for this not happening is because it's, you know, it's very challenging. But for instance, if we take, you know, another model completely like Interpol, they have managed to establish systems, computer systems, where computer systems and countries can talk to each other with that level of data. On a hopeful note, they have established a new hub for pandemic and Epidemic Intelligence in Berlin, so that's WHO, so hopefully that is the start of something like that. And I think, as Philip has said, the unique health identifier, we've been talking about it for years. It is so wonderful to hear other people talking about it, because I think, we need champions. It's hard in public health. We need people to help us, and that was very apparent, during the pandemic. And we need that whole thing of the data so that primary and secondary care are linking with each other. So that's one of my points, I suppose, about improving that whole surveillance system. My second point really comes back to what the others have mentioned around health equity. As Cathal said, we just had a conference literally 2 days before this whole thing kicked off about that topic. And, that's a huge lesson from the pandemic, was that the people in our society who suffered most from COVID were those who were most vulnerable, in direct provision or ethnic groups and so on. But it's a real lesson to us that we need to start measuring, equity. We need to measure race status consistently across our systems. There's no consistency at the moment. Mostly it isn't measured, even though there's a legal requirement to do so. So we really need to get to grips with that. And my third point is about, I suppose, future surveillance, and it relates again to what Philip was saying. There's a couple of things. One, we need to start thinking outside the box. For the last pandemic, the H1N1, the first thing that was really noticed was the Google searches for flu-like symptoms went up. We need to be thinking and looking at things like that and seeing what can really forewarn us about these things. And the other point is the point also made by Philip about the whole climate change and the surveillance of the issues around that. And that's something we're beginning to look at in Ireland, or here ourselves, we feel very passionate about it. We need to incorporate measures of climate change into our surveillance systems. That includes public health surveillance systems. Like in my day-to-day practice, we would deal all the time with water issues, bacterial contamination of water, flooding, all of that kind of thing. But we have no system, we're not measuring it in any way, really. And just a couple of final points, I suppose, in reflection to Philip's points. I think the point about communication, that was another huge lesson for me in the pandemic. It's just such an art and a science in a pandemic. I think we need a lot of research into that for future, to be honest. And I'm delighted again to have some help saying that we need to strengthen local public health. That's long overdue and very welcome, and thank you for that, Philip. And indeed, Mike Ryan and the WHO says it's all about having a very strong local public health system. And in terms of the I suppose, strengthening research and academic links, it's absolute music to our ears. And we are aware that there will be some appointments, kind of joint academic appointments coming in public health. And we're very excited about that. And I think if I was to wave a magic wand, I'd probably love to see something like they have in Canada, where they have 6 centres across the whole of Canada. One of them focus with an academic unit, one focusing on a major public health topic. So there's one that just does infectious diseases. They have work with practitioners in public health and the academic side. One just does environment and health, for instance. One just does health inequalities. One does kind of public health methods and so on. So that would be my dream come true. There are the points I want to make, and thank you very much for the opportunity to talk. I think, all pandemics do end, so just wanted to finish on a positive note. Okay. Thank you very much.
Thank you very much for that. Can I also say that we as a university very much much appreciated collaborating with Public Health Midwest in terms of developing the measures to protect our communities that we serve. So thank you for that. Catherine, can I invite you now for your statement, please?
Thank you very much. Thank you, Philip. That was a wonderful talk, and I very enjoyed it. So obviously, I come to this from the acute sector, and particularly from intensive care. And there was a huge emphasis on intensive care, because this was a global pandemic of a severe acute respiratory illness, and there was much emphasis on ventilators, how many we had, how many we didn't have, and all of that at the beginning of the pandemic, though it was always my view that not getting to the ventilator stage was the aim of everybody. So we knew in Ireland, and we'd known for years, even despite the H1N1 pandemic, which significantly challenged us at the time, that we didn't have enough beds. We didn't have enough beds with or without a pandemic. We knew that we should run at 70% occupancy. We knew we didn't have surge capacity, and we knew there would be certainly a significant increase in a need for respiratory support. And to be fair, we did actually reorganise our health service with a great emphasis on ICU and with a significant emphasis on acute medical care. And to do that, we did have to rob Peter to play Paul. So unfortunately, for services like the cancer services, scheduled routine screening had to cease. We had to redeploy, and we will hopefully catch up on that, and I'll let you speak to it, but it is a significant concern that I've had. In terms of ICU capacity, we didn't, thankfully, like other countries, get overwhelmed. What did worry us in the ICU community at the time was the presentation of normal, non-COVID cases almost disappeared at one point in time. So, and certainly, maybe it was the way we were living. Maybe lockdown meant that people didn't have strokes, didn't have heart attacks. So we had a concern about that, and that sort of data that we should look at in the future, I think will help us learn going forward to find out, number one, why it was those people didn't come, and if it was the fact that the way we lived was different, maybe that's something we can adopt in terms of our lifestyle. In terms of research and audit, there's an Irish Critical Care Trials Network, and certainly in UHL we contributed to a thing called Sprint SARI, which is a short period instance of severe acute respiratory. It's designed for pandemics. So the people who came into us, we got demographic data, we found out how long they were sick before they came to us, what their symptoms were, what their age was, and that contributed, that was worldwide. That was based in Monash, that was where it started, but it was actually a worldwide study that I think helped modelers with data in terms of how likely people were to get sick, when they were going to get sick. All of that was very significant and useful. In addition, there was audit, and we have a very strong audit system in the Irish system now, which is developed with Rory Dwyer and his colleagues in NOCO over the last 10 years. And there was also a parallel audit with NOCA, which we have been using since the H1N1 pandemic, which was kind of a homemade audit at the time that the ICSI and the Health Surveillance Society actually designed. So those figures and data were given to government, and I think presumably to yourselves as well, to assist in decisions about how stressed the healthcare system was and what the likelihood was that we would have difficulty. And they were really quite important. In terms of the research as well, in terms of the development of vaccines, it was absolutely amazing. Most of us thought we wouldn't see a vaccine inside of 2 years, let alone a year. And there never previously had been a vaccine produced, in my view, in that length of time. And the last thing I'll talk about is communication, because a lot of this data to the ordinary person in the street can be very confusing. But all of a sudden, the ordinary person in the street was interested in how many people were in ICU, how many people were in hospital, where could they go for whatever it was that they needed, and effectively, I mean, deciding whether or not to go to the supermarket. If you were a transplant patient, you know, I think you took a lot of notice of the local incidents and stuff like that. At least I think people did. And I think communicating that data was very important, that we did it in a way that people understood it. Communicating the benefit of the vaccines. Some of the data we collected in ICU was helpful there, because we knew once the vaccines came in that we were seeing people who were sick, who were unvaccinated, partially vaccinated, or who didn't benefit from vaccination. And communicating that to people was the carrot. The stick was you couldn't get in to eat your dinner with your children, but the carrot was it did actually make you better. But I mean, that form of communication, I think, is really important. And trying to explain to people how the healthcare system works, why this happens, that happens, the other happens is important. And the other bunch of people that really needed to understand why we were doing this is everybody who lost their jobs. And those people, in my view, besides the people who got sick and died from this disease, the huge economic cost and worry has always laid on me. And those were people in lower socioeconomic class, people who work in hospitality, jobs that come and go. Those people, I mean, seriously, in my view, needed to understand why we were doing this and needed our support. And they did get government support, in fairness, but I've always thought about those people because my job continued. We went to work, we got paid, we didn't have to worry about the bank and the mortgage. People did, and it was a huge problem. And also for people in jobs where they couldn't actually not go to work because they didn't have access to social welfare. Those people were also severely affected. So I think communicating the data was important. And ultimately, over the next year or two, we'll learn more about what happened. We'll learn more about outcomes of people who didn't present. And that will help us plan for the future and see if we can actually upskill and invest in our public health acute sector so that we can cope slightly better and perhaps not have to choose between scheduled and non-scheduled care quite as much as we had to over that 2-year period. That's my double statement words.
Thank you very much, Catherine. From acute care, and acute care was under huge pressure, and you all done, such an enormous job over a prolonged period of time to care for the sick, and also to reassure the public with the care that you devoted to the patients. To the wider implication, perhaps.
Thank you so much. So I'm a data scientist and a cancer computational biologist. That means I work with the data. And I moved from Boston to Limerick during the pandemic, and I suppose got to see things from two perspectives. And I think the main there's 5 points, I think, or 5 key critical things I think that we've learned during this pandemic. And the power of data for making faster, better decisions is so important, but it relies on that there's infrastructure for digital health. It relies on real-time access to data, and I'll mention why some countries did better on that.